Test 1, 10, 2.
Got it, Eric. When you get that mic on, tell me, go ahead.
Come over here so I'll put this mic on you. So she's going to have two other speakers. I think they're going to speak after you finish. So what I'll need you to do is when you get through taking the questions, if you'll just come over here, let me get this mic off of you because I'll have to put it on them as well. So you can just pop that in a pocket anywhere.
Yep.
It'd be good to
And
go.
is this on right now?
Yes, you are.
Okay. Okay. Okay, everyone, I'll go ahead and get started while folks are still grabbing some lunch and the like. There's still plenty of food left. I'll introduce myself quickly. My name is Keith Sweth. I'm a palliative care physician who's interested in providing care to patients that have advanced cardiac disease. So I was asked to talk today really about some of the challenges that we face with patients that have advanced heart disease, particularly advanced heart failure, and challenges associated with readmission. So we're going to focus on some of those. Involve a multidisciplinary approach, and what I understand, many of you are part of that multidisciplinary approach and interdisciplinary team. So I'll be really excited to hear some feedback as we move forward. So we're going to talk about transition points in the heart failure trajectory and opportunities to engage palliative care as available. We're going to talk about communication, and we're going to talk about post-hospital options to support patients and families at key transition points. And I'm really fortunate to have some great colleagues in this field, and I always like to give them some credit. Dr. Moana Carlikar up at Vanderbilt, Dr. Shannon Dunley at Mayo, where I've worked with her for several years, and Dr. Wordingham at Mayo, Arizona, and then Dr. Orr has been very gracious in terms of looking at how do we help folks with advanced cardiac disease, particularly those that are in the skilled nursing or long-term care facilities as well. So the first couple of slides I think will be no surprise, and it's really to build the case that the burden of heart failure in the U.S. is quite substantial. And really when we think about advanced heart failure, it's really a final common pathway that we see for patients regardless of each year. And when we look at 5-year survival following the first hospitalization for heart failure, we see that that 5-year survival is 25%. And I think one of the real challenges is if we have someone who comes in and has a new diagnosis of non-small cell lung cancer, new diagnosis of ALS, to say that 5 years from now they have a 1 in 4 chance of not being here anymore resonates and seems to compute. But to talk to somebody who has advanced heart failure and say that, again, your 5-year survival, there's a 3 in 4 chance you'll be here, a 1 in 4 chance you won't, that really is. Can't we treat heart failure better? And the truth is that we do treat it better. We treat it better to the tune of $32 billion per year in this country. And some of those cases are related to kind of bread and butter. Some of those cases are related to very, very advanced basis of catecholamines and readmission rates due to just struggling with managing the day-to-day. Related to heart failure. There's issues related to that pulmonary congestion that we talk about that can happen on an acute or a chronic basis. There's issues related to sleep disordered breathing. There's issues related to dysregulation of the renin-angiotensin-aldosterone system. Adequately relieved in anywhere from 60 to up to 75% of our patients that have advanced heart failure. So one of the things that's been really challenging in this population is what about the issues with readmissions with heart failure? And we kind of get this put upon us, and I like in this paper by Desai and Stevenson, which we'll look at a couple different slides, their finishing line of the paper was, as Albert Einstein noted, not everything that counts can be counted, and not everything that can be counted counts. And I think this is really, really true when we think about folks with advanced heart failure. It's very easy to say, 30-day readmission, they're back 3.5 weeks later. Obviously, you didn't do a good enough job. And the truth is, socioeconomics, but it's really not just that one person didn't do their job. Of course, there's going to be the time when someone, oh, I forgot to prescribe that furosemide. Maybe it's that there's other issues that it was filled, but I don't take it because I hurt and I'm so stiff and I can't get out of bed to pee 90 times a night, so I'm just not going to take it. On that. But really it comes down to that just because that's a measure and we want to make sure that we're looking good in terms of metrics related to readmission, it's a much more complex problem than that. But again, CMS has to try to look at how do we optimize the funds that we have. So there were lots of initiatives that were introduced to decrease readmissions related to heart failure and acute MI, surgical complications, pneumonia. And really it was looking at, again, how many patients were discharged and readmitted for the same problem within a 30-day period. And many of you in the room probably understand the finances of the quote-unquote penalties related to CMS reimbursements for hospitals and healthcare systems that are 2 standard deviations above and what that actually means to the bottom line. And I'm sure there are folks in this room that have a very clear idea what it means to the bottom line at this particular hospital. But we know that that saves $8 billion overall projected to CMS. But again, saving money and looking at this 30-day marker is only one facet of a very, very, very complex problem. So going back to that paper by Desai and Stevenson, when we think about kind of looking at how people go through their initial diagnosis with heart failure and go through their life, there really comes down two time points or 2 time ranges when people are probably at the highest risk for readmission. When we think about the transition phase, we're really talking about the initial ischemic event or the first volume overload from poorly controlled blood pressure and heart failure with preserved ejection fraction. So in that initial phase, we certainly have a real high risk for readmission. And then overall, when we think about the situation related to et cetera is. And then at the end, we think about what are the true priorities? You know, palliation, what are the priorities? Is palliation a priority? Is palliation our priority? A very, very profound impact on mortality. It's my recommendation that we don't intubate you. It's my recommendation that we turn your ICD off because this is going to be more likely to be associated with harm than good in this particular situation. And I think about a patient who we had very nice discussions with who said, you know, my goal are to enjoy the simple things in life as long as I can. And within 6 hours of getting home on hospice, he had cardiac arrest. And what did the family do? They resuscitated. And what did intubation lead to? Readmission. Is that a palliative care team or a heart failure team did a bad job in that situation? Absolutely not. But it does behoove us, it's not just a matter of the person coming back in and being readmitted to the hospitalist team or the cardiologist team for volume overload, but are we really recognizing that this is part of the greater process of an end-stage heart failure state? That it's not just advanced heart failure, it might be an unfixable problem. Or as my colleague said, with the masters coming up, it makes sense. He said, sometimes you're just in an unplayable lie. Now, Tiger Woods had one that was kind of wedged in against the lip of the sand bunker, and I saw he got it up and played it, but that's Tiger Woods. Many of us as clinicians aren't the Tiger Woods of our fields here. So, and even if we are, sometimes it's just really, really challenging to say that we want to do no harm and we want to protect what we consider to be dignity for you. Yet, by the same token, patients and families have different understandings of what that means. But I think this slide is super important, and I apologize every time it doesn't always, the hash marks are each a half a year. If you can't see that in the shadow, it came out as a shadow. But when we look at this and think, what are the risks of patients in terms of if they're hospitalized with advanced heart failure and then subsequent survival, chronic kidney disease with their 3 years. That's not super good. We talked about a 5-year mortality of 25%. We're talking about a median survival of 3 years. But again, for someone to come in and say, oh my gosh, I just have heart failure, I just need to take some ACE inhibitor and diuretic, and this is a problem, it's really, really hard sometimes to wrap our head around that this is almost as bad as having a diagnosis of some cancers that we just can't fix. If they have chronic kidney disease, you see that the survival overall halves. And then as you add age to that particular factor, those between 75 and 85 or those between greater than 85, each subsequent hospitalization. So we know that if you're hospitalized with heart failure and then you're rehospitalized with heart failure, whether it's 30 days, whether it's 60 days, whether it's 6 months down the road, that represents a very important transition point. That even if you don't have underlying kidney disease, that your survival essentially has been cut in half. And when you add kidney disease and you add the inability to potentially diurese folks as optimally as you can, you run into cardiorenal syndrome, you run into issues with how do we do with volume sensitive patients who are very sensitive to volume, but also when we diurese them, they're very sensitive to decreased renal perfusion and bump in creatinine, BUN, potassium, all the things that you see time and time and time again. So each subsequent hospitalization, it's not just a little blip on the radar. This really is something that says when the person gets rehospitalized, this has very, very direct impacts on what their overall survival is. Now again, we looked earlier at that two kind of biphasic, bimodal distribution where people early in the process and then later in the process have risk of rehospitalization. But I think this kind of gets to the point from Larry Allen and the group with the AHA, ACC guidelines on shared decision making, that again, sometimes people have an initial event, they have high intensity of care, they have decreased quality of life, but we get them better. We get them optimized, we get them revascularized. And then sometimes those folks experience sudden death, and that's often not a problem anymore because if we think someone's at risk for sudden death, they get a vest, or they get an ICD, or they get other types of therapies that we recognize that, okay, if we do this earlier on, we might prevent that sudden death. So they get through that phase. And then when we're looking at more the chronic phase, it really comes down to these recurrent decompensations where persons just don't get back to the baseline they used to be at. So when we think about that shaded area, it really comes down to when we're seeing, again, there's the first exacerbation, the second exacerbation, now we're into the third exacerbation. When we're thinking about that, is it really that the oral therapies we have aren't working? Are we limited by what we can do medically? Are there issues with compliance? Or is this a time when we have to think about major decisions? And when people see ads for things like left ventricular assist devices, and the person's there climbing a mountain, and it says, if I did this with my LVAD, you could do this with your LVAD, then it becomes something that's very, very appealing to the patient. And then they say, well, why can't I have a left ventricular assist device? Well, why can't I go on and have inotropes? Or why can't I go on and have these other types of treatments? And it's not that people necessarily can't, but there's a lot more that goes into it than just having heart failure. There's things that we can look at that, again, predict who might do well with an LVAD and who's not going to do well with an LVAD. And it's not just the medical side of things in terms of, do they have concurrent right heart failure? Do they have arrhythmia issues? Do they have issues related to bleeding already, and now we're going to put them at higher risk for bleeding or thrombosis related to their mechanical circulatory support? But it really comes down to, how much of a caregiver do you have? What's your home situation like? What's the likelihood that you're going to deal with an infection and then deal with the driveline infection and then deal with the device infection or thrombosis or the other types of problems that we see? That it's not really just about, can the clinician technically put in the device? Because I know many cardiothoracic surgeons who are more than capable and able of putting in a left ventricular assist device. But it really comes down to, outside of the operating room, outside of the ICU, when they're transitioning into the community, how well is that person going to do? And that becomes the challenge. And then again, if we think about these issues and we think about that our person may not be a good candidate for some of these advanced therapies, then what are we doing to offer them the alternative? So early on in my career, I talked very closely with my cardiologist and my surgeons. It's really not, informed consent for an LVAD isn't, do you want to get an LVAD or do you want to die from your heart failure? Like, that's not really informed consent, because you may die with the LVAD anyway, and there's things that we can do. What can we do to help your quality of life, help you live the best you can as long as you can? And that's really about selling supportive care for patients with advanced heart failure, because it's not about saying we don't want you to come back to the hospital. It's not about saying we want to take medications away. It's about saying, how are the medications that we have actually helping us to help you to achieve what your overall goals of care are? If you want to enjoy the simple things in life, how is a mechanical ventilator 6 hours after you get home, back in an ICU at an outside hospital, how is that helping you enjoy the simple things in life? Because if we go in there and say, well, I think you should go on hospice and we shouldn't do anything anymore, then of course they're going to say, I don't want that. That sounds god-awful. And I'm so grateful to hear that our hospice folks are here today and are going to talk to us a little bit about how do we couch that and how do we really give people an accurate understanding of what hospice services might mean or what palliative care services might mean or how these are actually different. Lunny and Lynn looked at how people die a few years back, and this is, again, 15 years ago now, but I think it's still a very telling slide, where, again, when we think about heart failure, we think about a proportion of patients having that sudden death, but really when we're thinking about heart failure, it's often a combination of the bottom two: progressive organ failure and progressive frailty related to their advanced heart disease. And one of the real challenges is when we talk to patients about what this overall means in terms of prognosis, I think it's sometimes hard to wrap their head around what end of life might actually look like. So I could think back to a patient who had progressive cardiorenal syndrome and intolerance of hemodialysis, and the son, his framework was, I just want mom to die in her sleep, and then I don't have to make these decisions. And the truth is, that puts you in the upper left quadrant, the sudden death, and that only happens for about 10 to 15% of patients. And if they have an ICD on, we're robbing them of that sudden death, unless they get PEA or something like that. But if they have an arrhythmia at night that's readable, then they're going to get shocked, and we're not going to allow them to just die in their sleep. So again, it's not a matter of saying, I don't want to provide this therapy. It's a matter of saying, how is this therapy helping you to achieve what you want it to? So initially, when you got your ICD placed, it was because you had things to live for. You wanted to get to the wedding. You wanted to get to certain accomplishments. It's because you still could go out in the wood shop and you wanted to be able to do those things. But now you're bedbound. Now you're not able to leave the house. Now you're profoundly short of breath. The reason we put this device in may not, and what its goals were, may be very different than what it's accomplishing right now. So helping people to understand that the frailty and the dwindles, the recurrent hospitalizations, the recurrent exacerbations, these are the things that we tend to expect with cardiopulmonary disease that are different than patients who have advanced cancer and go through line 1 of chemo, line 2 of chemo, line 3 of chemo, each one saying your survival might have been 60%, now your survival is about 40%. Now when we're on third line for solid tumors, we're looking at a 10% chance of survival. Now granted, biologics and immunologics all change this, but at least we know when we're thinking about standard solid tumors, they're the ones that kind of fall in the upper right corner. And folks that really experience that are about a quarter to a third. It's really about half or more of our patients that fall in the bottom two boxes here. So when we think about our elderly patients, particularly with advanced heart failure, it really comes down to a lot more factors than just what is their ejection fraction, when was their most recent echo, are they on an ACE inhibitor, to think about what's going to help this person do well or not. Some of that's related to multimorbidity. If they have heart failure and COPD and uncontrolled diabetes and peripheral vascular disease and an amputation that's not healing and prostate cancer that's on hormonal therapy, that is very, very different for a patient who has the exact same age and just is dealing with heart failure. And I went to medical school about 15 years ago now, and I used to be able to think when I was on the medicine service, oh great, I'm on Gen Med, I'm only going to get an admission for COPD exacerbation, or I'm only going to get admission for cellulitis. How many of those admissions do we really get if you're a hospitalist, that they're just coming in for cellulitis or just coming in for a COPD exacerbation? Usually it's lots and lots of complex problems that aren't easily fixable with cefazolin. It goes way beyond that. Cognitive impairment. And again, when we think about cognitive impairment, it's not just cognitive impairment because of advanced age or underlying dementia or poor perfusion, but also this fits into social literacy, social economic status. What about their medical literacy at a baseline? What do they understand about what it means to take your diuretic twice a day, and when to take it, and when to check your blood pressure, and what it means to be weighed every day and do it at the same time, dressed the same way, etc. Versus, well, one day I weighed myself with my clothes on, and then the next day I didn't have my clothes on. What do they understand about that? Very important. Functional limitations, again, when we're dealing with frailty and functional limitations, we're dealing with weakness, we're dealing with mobility issues, we're dealing with potential peripheral vascular disease. All these things really lead to some of the challenges that we see with advanced heart failure. And when we look at this slide from Arnett and circulation and think about patients that have heart failure, again, those underlying problems all can still contribute to the person's overall demise. Hypertension, ongoing ischemic heart disease, lipid issues, diabetes, chronic kidney disease, osteoarthritis. Again, is it a fatal illness? Might not be a fatal illness that we think about. We might think about it, it's a fatal illness if we give opioids and they overdose, and we don't want to do that because we gotta not write for opioids for people that don't have end-stage processes. But then is this a person who has osteoarthritis, isn't having appropriate pain management, and now can't get out of bed and move around, and doesn't, and develops blood clots, and develops issues with sores, and develops issues with compliance because I'm not going to take my diuretic because it just hurts too much to get up and pee. So I don't want to do it. So I'm not going to take that Lasix or whatever they call it. I hear lots of fun different names that people have for it. And I'm sure you've all heard them too, but they don't want to take their diuretics. Rate control, atrial fibrillation, big issue. See a lot of people that come in. Am I worried so much about, in my field about CHADS-VASc2 scores for my patients. Again, I kind of see a sicker population than a lot of folks probably do. But in this particular situation, I do absolutely care about rate control. Because when the patient has a heart rate of 130 and they can't breathe and their pressure is tanking, then they're going to come back to the hospital. So, when we think about polypharmacy and rational polypharmacy for our patients with advanced heart disease, we have to think about that palliative care and even hospice is not an approach where we just stop everything and start morphine. Because when people think we're going to stop everything and start morphine, then they don't want to do it because I heard about that morphine and I know what that does and I don't want to take that morphine. But when it comes down to it, we really have to ask ourselves rationally, if someone has advanced cardiac disease, is a diuretic something that's optional or is it essential? Is the beta blocker or calcium channel blocker something that's essential or is it something that's optional? Is the statin something that's essential or optimal? And we could think about Gene Kuttner's study from JAMA Internal Medicine 2014 that said, if we're thinking about this whole concept of deprescribing, that statins are certainly a medicine that can go more quickly than others. But again, we have to think about, does this person have active coronary disease? Does this person have active peripheral vascular disease? Are we worried about some of those issues with plaque stabilization? Those folks were excluded from that study. So, I was fortunate enough to be on that, one of the sites that was on that study, and I'm a big proponent of deprescribing, but I'm also a big proponent of, if someone doesn't really meet the criteria, yes, someone with pancreatic cancer, limited life prognosis probably doesn't need to be on their statin. But if someone has active ischemic heart disease that's leading to active angina and active heart failure, it's not just to start a morphine and stop everything else. We really have to think about what's the right thing to do in this situation. Getting back to reasons why people get admitted, again, when we look at the signs associated with some reversible things like frailty, weak grip strength, and slow gait speed, we can see that, again, that puts people, again, 16%, 30% respectively, in terms of risk of rehospitalization. And the mood symptoms, yes, absolutely. The mood symptoms do, because when people don't feel good about themselves, when they don't feel good about the future, it's very hard to help them to feel good in terms of things somatically when psychologically, emotionally, spiritually, existentially, things aren't going as well as one would hope. So we think a lot of times about getting our folks to the skilled nursing facility because, again, well, we don't want to put them on hospice and that might not be appropriate, or the family says we want to go to rehab because, again, we want to think about maximizing our benefits, because if they go somewhere else, if we don't put them on rehab, then we can't use our Medicare benefits for subacute rehab. So that's the only thing we can do. But when we think about patients who are discharged to this SNF for heart failure, are these people at lower risk for readmission? No. And I think part of the real challenge is, again, if we're not communicating well with our SNF about what the expectations are regarding volume status, regarding physical therapy, regarding symptom burden, and someone's having exacerbations of symptom burden without any clear plan in place, they're going to come back to the hospital. They're going to come back because the skilled facility is going to say, we can't handle this. They can't do their rehabilitation because they're short of breath again. So then it behooves the question, was that the right place to send them? And sometimes, again, we're limited by this healthcare system we all live in this area we all live in, by some of the resource issues that we have. So when we think about readmission specifically, before we focus on palliative care or follow up with palliative care, there are lots of different sites that you could look at that have looked at different types of programs, and there's certainly variable efficacy with each of these in terms of how do we make sure medicines are reconciled, are they getting the right medicines, how do we telephonically monitor them. We're fortunate enough at UAB that Marie Bacaitis is a PI on the Enable Heart Failure HF study, where again we're looking at patients who have a risk for readmission, and we're worried about what their overall prognosis is. Are we equipping them with tools of self-efficacy, with tools of advanced decision making and advanced care planning and advanced alerting of symptom burden so that overall people can have potentially better outcomes. And there's lots of different programs that I've looked at telephonic monitoring, whether that's just talking to a nurse or case manager, or whether that's using very, very fancy, nifty, implantable things that go into major arteries around the heart and give us information like continuous wedge pressures or central venous pressures. Again, lots of different studies have been done on that, variable benefit. Again, it all comes down to not just having one simple little device implanted, it comes down to how that simple device is going to inform our healthcare providers, our multidisciplinary team, to provide the best care for these folks that we can. Self-management education, disease management, coaching, care plans, clear instructions. Again, how many times do we give people discharge summaries or instructions, and there's a literacy issue where they just can't read it, or they just can't, or there's a cognitive issue where they just don't understand it. They hear you just fine, but they just don't understand what it means. Not that uncommon. When we think about some other programs that have been done more community-wide, I'd certainly be interested to hear what's being done in Ascension and within St. Vincent's in terms of hospital groups partnering with local physicians, in terms of making sure communication between communication loops with discharge summaries, with follow-up visits, with appropriate information that helps the clinician to understand what the heck actually happened in the hospital versus just a whole bunch of check boxes that meet certain criteria but don't really help us to say, how do I pick up this patient's plan of care, which is already pretty much complex, and how do I make sure that the ball's not getting dropped on something? So this is one model that's been talked about in terms of disease management. And again, this is proposed in the Desai and Stevenson model, and it looks complicated, and there's a lot of different things that are in here. But the reason I put this in is not so much to look at one specific issue, but to say these are lots of different things that one could consider. And within your own healthcare system, are there certain markers that would say, what's the role of the primary care practitioner? What's the role of the general cardiologist in the situation? What's the role of the subspecialist? How do we think about, what are our goals? Are our goals really related to all-cause hospitalizations? Are they related to mortality? Are they related to improving function and quality of life? Or they even put in there in a very dashed line, improving quality of death, which again is a very interesting concept. If we have an end-stage process, do people get care that's congruent and consistent with their goals and values? Well, the person who I mentioned getting reintubated and in the ICU, we might say their quality of death doesn't fall good on an overall marker, but in terms of meeting their goals of care, it absolutely met what their goals of care were, despite several attempts at education. Also in that paper, they talk about some different concurrent models with not only thinking about traditional heart failure clinics, but working with home, working with when people present to the emergency room. Are there ways that people can get early access to parenteral diuretics if they need to? There are some places that are looking at, again, if the oral medications aren't working, can we bring people in, not have them come back to the emergency room? But if they're part of a disease management program where we could get them parenteral furosemide, parenteral bumetanide, again, to try to get on top of things before they get to a point where overall that's going to be something that once they already get down that road and get down into the emergency room, often that emergency room, the path of least resistance is the hospital, it's an admission. But how do we, from a pre-hospital perspective, think about what resources we have in terms of education, in terms of monitoring, in terms of self-efficacy, to make sure that people don't necessarily run into these problems on a repeated basis. So again, when we think about what the patient with advanced heart disease needs, they may have a heart failure-specific cardiologist or heart failure-specific nurses, but what's the role of the pharmacist? What's the role of the social worker and the healthcare communities great example from patients that I've heard, on the ENABLE trial. It's really, really great to say that they have a follow-up appointment to be able to get weighed, but if they're so immobile and short of breath and can't get there, and oh, well, we'll give you a bus ticket. Well, the bus is 6 blocks down, and if you're short of breath and not feeling well, 6 blocks is not necessarily something that you're going to be able to do. So, oh, you just don't follow up. So what are some models, again, that don't necessarily depend on people coming back, but what kind of community resources? What's going to be the role of home-based palliative care? So we know that there are some programs and more programs coming within this community through more providers that are not providing home-based hospice care through the Medicare benefit, but are often providing home-based palliative care for disease management that's often through a different model, Medicare Advantage or something as such. Making sure that, again, the foods are taken care of, where sodium is hidden, it's amazing. And then again, is there something that the primary care feels empowered to do? Does the primary care clinician feel unempowered to manage some of these things? And subspecialty palliative care on whatever level might be something that would be appropriate. So again, when we're thinking about our patients who are leaving the hospital, again, the challenge I often have is we put some people into this rehabilitation group or the uncertain prognosis group, and they end up getting a situation where we're labeling them that, but what we're really seeing is that they have advanced, unfixable underlying heart disease, and their risk of exacerbation or long-term problems is something that is not going to be well met in the rehabilitation group or in the, again, uncertain prognosis group. It's absolutely fine to put someone in the in the uncertain prognosis group, but the most important thing to do whenever we do care along that line is to make it a time-limited trial. So if we start dialysis for someone, it's not a matter of saying, well, they're here at St. Vincent's East, they're going to get a central venous catheter put in, they're going to get started on dialysis, and then when we leave, it's not our problem anymore, some dialysis center will take care of it. Do they understand that? Well, if we're going to start dialysis, we should be looking a month down the road. We should be looking 2, 4, 6 months down the road and saying, is this dialysis helping you? Is it helping you to achieve what your goals of care are? Is it something that's manageable? Or is it just something that was started and the inertia or the misperceptions of what it means to start a life-sustaining treatment are something that aren't going to get revisited? Because when it's not revisited, that's the time when people come back and are rehospitalized again, because these issues haven't been revisited. So it's fine to be in the uncertain prognosis group, and it's fine to be aggressive, but we really have to think about how do we follow up to make sure that all that aggression is helping the person to meet what their goals, preferences, and values are. And again, I've used this slide for talks here before. It's not just about survival. It's not just about what their BUN to creatinine ratio is. It's not just about whether we keep them out of the hospital or not. It's how is the treatment that the person is picking helping them to achieve quality life, and what are the costs and burdens of said treatment? For some persons, home inotropes might be a very, very reasonable thing, but even with the insurance that they have, the burdens of that therapy, whether that's not just the money to pay for the inotropes, but the care that it's going to require, the safety in the home environment. Is that a situation where the burdens of that therapy outweigh what the actual physical or other costs are? And I always say these circles all look very concentric and have our patient at the center, but we all know that no patient looks like this, that each patient has different understanding under prioritization of each of these specific domains, and it's really our job as clinicians to think about how do we think beyond survival? How do we think beyond the fact that this is a 5-year prognosis with a 25% mortality after your first admission? We could quote those numbers, but how do we actually use those numbers to inform plans of care that help patients to achieve quality of life, symptom management, and to help them live the best they can as long as they can? Sometimes this issue with DNR is tricky. I've been there before, and well, why wouldn't I want to do that? Last time I was on the ventilator and I got off it, why wouldn't I want to do that again? Well, maybe someone's at a different place right now. And that's a very simple language, but it's been shown to be very helpful. We're at a different place now. How do we help them to reframe? How do we help them to remap what their course of overall care is? When we think about advanced care planning, the data, it's very challenging. And Shannon Dunley, again, did some great work where said not even half of patients in the community had advanced directives. And if they did, they really didn't address the things that were related to their advanced cardiac disease. When we think about CPR or dialysis or ventilation, they might say things like, if I'm in a vegetative state, don't sustain me. But that doesn't help because, again, our patients with advanced cardiac disease, unless they're going to have anoxic brain injury from an arrest, they're not going to fall into that vegetative state. They're going to fall into the frail and continuing relapsing and remitting course of treatment. So when we think about goals of care, again, it's really not just helping people to think, are your goals of care related to do you want to be resuscitated or not? Thinking about goals of care really gets further out in terms of, do you want to be cured? Do you want to live longer? What's your expectation about this? What's your expectation about being independent and comfortable? And what are your life goals? Do you want to wait for that child to graduate? Because sometimes when we ask about these things, we hear various information and things that we might not otherwise hear. So basically what I'm going to do at this point is to allow time for questions and for our other speakers, I'm going to stop here. The other information in the slide set that you have is about transitions of care. So there's really some great information just again about how some clinics are set up, how palliative care sometimes can be integrated to identify transitions in care, but also to facilitate smooth transitions in care. But I think this is a really good point to go ahead and stop, and I'll be happy to take some questions moving forward. Or it all might just be so easy that we just do this all the time, which... Well, I'm not going anywhere, but I do know that we have some other folks that would like to speak today. So I will step aside and be here for a few more minutes if there are individual questions, but let me at this time ask my colleagues to come up and talk a little bit about some of the resources that are available here.
Am I here? Hi, can y'all hear me? My name is Christy Falligant, and I'm one of the social workers at St. Vincent's Hospice. So I'm here to talk just a few minutes about hospice, and then we have someone to talk about palliative care. So just briefly, so again, I'm one of the social workers at St. Vincent's Hospice. I'm a hospice and palliative care certified social worker. This will really age me, but I was actually the first social worker in the state of Alabama to be hospice and palliative care certified, so I've been doing this too long, I think. But more importantly than that, in terms of hospice, I've had 3 family members on hospice. 2 were really great experiences. 1 was not a great experience. So I know what that's like to be on that side. What I understand, I have about 5 minutes, and I'm trying to balance all of this and my paper. Can I set this down? Okay. So in my few minutes, what I'd like to do is just talk generally about hospice, talk a little bit about the benefits of hospice, or really what that looks like for your patients, and then talk briefly about who's eligible for the hospice benefit. So you guys know this, hospice really does rely on an interdisciplinary approach to care. For every hospice patient we have a team that works specifically with that patient, with that family, made up of the nurse, the chaplain, the social worker, volunteers, all this group of folks that goes to where that patient is. In order to be eligible for the hospice benefit, patients must have a terminal diagnosis that if the disease progresses the way that it typically does, then the expectation is death in 6 months or less. Now, having said that, I will tell you we have patients that are on our service for 2 days. We have patients on our service for 2 years. You know, nobody really knows except God or some higher power. But if the disease trajectory, if the disease progresses the way that it typically does, then the expectation is death in 6 months or less. To help determine that prognosis, Medicare has guidelines, of course they have guidelines for everything, for non-cancer diagnosis to help determine eligibility. And I think that's either on a handout or we can get that handout for you. But the bottom line is, if you're considering hospice for one of your patients and you're not sure about the prognosis, you can always order for hospice to evaluate to see if that patient's eligible for the hospice benefit. So the nurse will go to the patient's home or come here to the hospital if they're still in the hospital to determine if that patient meets the criteria, and to talk with the patient and family about their goals for care, because that drives everything, right? You know, we have some families who'll say, this isn't the quality of life that mother would want. She'd be horrified to be in this situation. We just want her to go home and be comfortable. We have other family members who'll say, my mama is not dying on my watch. I don't care what condition she's in, we're keeping her alive. So neither one of those are right or wrong, but we need to have that conversation about goals so that we're providing the interventions and doing the things that that family and patient wants. If that family and patient, if they're not eligible for the hospice benefit, then we work with the case managers here to try to help them and make recommendations for what would better meet their goals. So for example, if it's more of a palliative approach, or if it's better for them to have home health. So the benefits of hospice. What does hospice look like for your patients and families? Medicare says home is wherever the patient is. So the patient can be at home. Hospice can be provided in a nursing home, assisted living facilities. We provide hospice care to patients that are in shelters and boarding homes. We have hospice patients that are living in motels. Medicare says home is wherever the patient is. So we have this whole interdisciplinary team that visits the patient wherever they are. So again, nurse, chaplain, social worker. We provide aids to help with bathing and personal care. We have volunteers who can either run errands or go sit with the patient so the wife can get out and go to church. Hospice patients can get PT and OT services, not for rehab, but for short-term, maybe to help patients learn strength training or help train that wife on how to safely transfer that patient. We really work hard to help families understand that when that patient's on hospice, we're like their personal 911 service. If they get scared, if they have a concern at 2 in the morning, they call us. We say, we've got people that work all around the clock. You're not going to wake anybody up. Go ahead and call us. We'll get the nurse out to the home. So hospice is like that family's 911 service. When you refer a patient to hospice from here, we make sure that everything's in place in the home before they're discharged. So we want to have that equipment there. We want to have the bed. We want to have everything set up. And then, of course, when the patient dies, the hospice nurse attends all the deaths, provides the post-mortem care, calls the funeral home. Our team stays with the family until the body's picked up. And then, of course, with every hospice patient, bereavement support is available to that family for up to 13 months following the death. So in addition to all that, one of the great benefits of hospice is those concrete needs are met. So all the equipment, all the supplies, all the medicine, everything that's related to that terminal diagnosis is covered by their hospice benefit. Hospice bed, oxygen, all the medicines, which by the way are delivered to the door, all the medicines, diapers, insure, all that stuff, everything that's related to that terminal diagnosis is covered by that hospice benefit. That's a huge concrete benefit for those patients and families that are really struggling to pay for those adult diapers or those cans of insure. Okay, so real quickly, for your patients that are on hospice, hospice has 4 levels of care. Any hospice has this. It's a Medicare thing. So the primary level of care is called routine care or routine home care, which is confusing because people think it's home health, but it's not home health. It's just called routine home care. That's where 99% of the patients get their care 99% of the time. That's where a nurse comes to the home intermittently every week or twice a week or 3 times, whatever it is, and provides care to that patient in the home. That's the routine care. If patients have a symptom that can't be managed with that nurse coming intermittently, then the next level of care is called continuous care. Some people call it crisis care. So if there's a symptom that needs to be managed, we put a nurse at the bedside around the clock. It's evaluated every 24 hours. It's not a long-term at the bedside thing, but we want to get that nurse at the bedside. So if they're having uncontrolled pain, uncontrolled nausea, uncontrolled bleeding, respiratory distress, we want to have that nurse at the bedside until we get that symptom under control. If symptoms can't be managed with that nurse at the bedside, then the next level of care is called GIP, general inpatient. So that's where that patient comes here to the hospital or anywhere that we have a contract. And that care is managed here in the hospital until that symptom is under control, and then they go back home. The last level of care is what I think is like the best kept Medicare secret there is, and it's called respite care. So for patients that are on hospice, Medicare recognizes that caregivers just need a break. The respite benefit is provided not so much for the patient's benefit, but for the caregiver's benefit. So roughly every 60 days, Medicare provides for that patient to go to a contracted facility for 5 days and nights to give that caregiver a break. Caregivers may just need to sleep. They may need to have their own knee surgery. They may need to spend some time with their grandkids. But it's to give that caregiver a break. Hospice provides ambulance transportation there and back. We have some family members who never take advantage of respite. We have other family members, I'm telling you, they mark day 61 on their calendar and they know when it's coming up, and that's okay. So who qualifies for hospice benefits? Again, there are a number of disease-specific criteria, but what I would say to you is there are real markers that indicate possible end stage of a disease. So if you have patients who present with progressive unintended weight loss, progressive decline in health in spite of all the hard work that you're doing, frequent infections, frequent readmissions or return trips to the ER, those patients that when they discharge you all say to yourself, oh, I know they're going to be back in 3 weeks, those should be a red flag for you. Basically, if there's been a significant functional decline, so if a family member tells you 6 months ago mama was up walking and now she's confined to the bed, that would be a red flag. And then finally, just if I could just say something just as kind of a worker bee in the field, a couple of misconceptions. One is patients don't have to have DNR status to be on hospice. We oftentimes admit patients who are full code status. You know, we all sort of arrive at acceptance of our disease process at different times. And sometimes it just takes families and patients a longer time to get there. So you don't have to have a DNR status. The other thing, just finally, I would just like to say as a social worker who's out there, I really would like to emphasize the importance of the words that we use with our patients and families. You know, I don't have to tell you how powerful your words are. When we admit a patient to our service and I'm seeing them for the first time, I usually say something like, tell me your understanding of the situation. Based on what you know, over the next 6 months, do you think things are gonna get better or stay the same or get worse? What has the doctor told you about your illness? More times than not, what people think they've heard is they said nothing more can be done. The doctor said nothing more can be done. Sorry, did that just deafen you? Can you hear me? Can y'all hear me still? Can you hear me? Okay. So oftentimes they say nothing more can be done. And what I would ask is to realize there is always something that can be done. For patients that are on hospice, there's a million things that can be done. There's a million things that we can do to keep patients comfortable, to support families, to have those symptoms under control. We can take out coloring books about grief for children. Our social workers can go with wives to the funeral home to make prearrangements. We can have the medicine delivered so that the wife doesn't have to get out in the rain to go pick it up. There's a million things that we can do. So we never want to say nothing more can be done. And the reality is, I do believe that most people are willing to accept the truth of their situation if they trust that their healthcare team is going to be honest and compassionate and true to their goals. Because when all is said and done, you know, we just want families to feel good about the decisions they made and what they did during this death experience. There's so many things here. Just a second, hold.
Can you all hear me? Yep. Okay, I'm just going to take a minute. You have a handout, and it says hospice and palliative care. So we have kind of divided out the services for those two. What I would really want to pass on is, again, let's have the conversation. When that patient is diagnosed with heart failure, that's a progressive disease, and it's heart failure. So what I charge all the physicians with is to say right up front, this is a progressive disease. We're going to do everything we can with medication and all, but you know, there are 4 stages, and typically when you get to stage 4, we're looking at improving your quality of life and helping you toward the end of your illness with palliative care and hospice. If you start out that way, then by the time that they get to stage 4, they've heard it and they're a little bit prepared. So that conversation can't start when they're at stage 4 and we're ready to put them into palliative care or hospice. Our new heart failure education booklets, one of the things we did is we put the stages in there. And it says in the book, at stage 4, typically palliative care and hospice are ordered. So we are trying to address that also. Case management may come to you and they may say, we want to have someone come and talk to the patient about palliative care and hospice. If the patient has never been broached before, then yeah, this is a shock. So, but on the other side of that, case management has the obligation, and there have been lawsuits related to this, that we present the patient with all their options. And there's a financial issue with not giving them hospice information. Hospice pays for their medications. Hospice provides that hospital bed free. Hospice provides nursing care. There's all sorts of things, the tech in the home that comes and does the bathing and things like that. And so all the diapers and just what she was talking about. And so we are denying them that financial assistance as well as the benefit of the service. So it really is imperative that we give the patient all their options. So at that, I'm going to kind of end with an example on just being very open and upfront when the diagnosis is given. My first husband was diagnosed with a brain tumor, and the doctor said to us that he was 60 at the time, that we're going to treat this like a chronic disease and he'll be on medication for the rest of his life. I'm thinking chronic disease, why, he could live to be 70s, which is a normal lifespan. And I didn't have a problem with him being on medications for the rest of his life. The rest of his life was 2 years. Now, it was pretty obvious as he started to lose function that he was not going to make it, and we did get hospice involved. But again, thinking about how your words come across and how you say things, where we don't want the patient or the family to lose hope, but to have an understanding that this is a progressive illness. Heart failure, they're going to continue to have exacerbations, and as those become more frequent and those types of things, they're going to have more problems. And in so doing, we're preparing little by little the way to introduce hospice and palliative care. Also in your handout is Aspire. Aspire is an outpatient palliative care. Insurance does pay for this service. There may be patients that right when they're first diagnosed, they need some palliative care. Palliative care can be very helpful in setting your goals of care and having those longer conversations with the patient and the family, and preparing them for hospice in the future. So we do have a palliative care nurse practitioner at Birmingham. We have a hospice educator for East, of course we can always get St. Vincent's Home Health and Hospice to come and do a consult at any of our facilities, but for those patients that really want to continue treatment, they are not ready to make that decision. Sometimes palliative care is a really nice intervention to get them, one, to work on better quality of life, but also to help them set their goals for the future and be ready for the hospice intervention when the patient is actually ready for it. So just look at your handouts, and I'm here to answer any questions. We'll answer any questions that you may have. So. Anything?